Welcome to Common Ground with SMK Medical, the podcast that aims to provide a platform for open and informative discussions on common issues in the healthcare industry. Today, we are joined by a special guest, Dr. Kenneth Scott Jr., a preeminent leader in the healthcare field. Dr. Scott earned his doctorate in osteopathic medicine from Kansas City University of Medicine and holds a Bachelor's of Science in microbiology from the University of British Columbia. With over 16 years of experience as a hospitalist, Dr. Scott has managed and led hospitalist programs. He's been called upon to rebuild failing hospitalist programs and served on hospitals boards for both for-profit and non-for-profit. Dr. Scott also has a passion for the post-acute care world and has been a medical director of various nursing homes across the U.S. for over 10 years. His unique blend of experience as a nursing home medical director and leadership in the hospital has led him to serve as a corporate medical director and eventually the chief medical officer of Life Care Centers of America. During his time there, he established a company, Life Care Physician Services, which continues to lead in providing excellent direct patient care and improving outcomes in the post-acute care and long-term care world. Currently, as the CEO of Silver Sage Management, Dr. Scott provides physician services to post-acute and long-term care facilities across the U.S. Dr. Scott currently serves as the medical director of Kula Hospital on Maui and works full-time taking care of patients at Kula Hospital and Lanai Community Hospital. We're honored to have Dr. Scott with us today to share his insights and expertise in the healthcare industry. So join us on this special episode of Common Ground with SMK Medical and stay ahead of the curve with our up-to-date and insightful discussions on all things healthcare. Before we dive in this interview, please like and share this podcast. Welcome, Dr. Scott.
Hey, thank you, Demetrius.
Hey, how you doing today? Thank you for joining us.
Great to be with you. I'm doing great, thanks.
Yes. So, for those that don't know, and I'm sure they don't know, Dr. Scott is a world-renowned medical director, expert in post-acute care. So we brought him on this podcast because a lot of our viewers are post-acute care executives, director of nursing, COO, CEOs, regional VPs and things. So they look at Common Ground for expert advice. So I brought you on, Dr. Scott, and I did a little introduction on you, but tell us who Dr. Scott is.
Well, I'm an internal medicine physician. I practiced for 17 or 18 years as a hospitalist. As you know, hospitalists send a good portion of their discharges to nursing homes, which I did. And then we kind of wait to see which one of those patients ends up back in the hospital, and we take care of them again. During that time of being a hospitalist, my senior partner recommended me to be the medical director of a nursing home. I'd never thought about doing that, I asked him, I said, why do you think I should be the medical director of a nursing home with everything else I'm doing, serving on the board of the hospital, helping to manage the hospitalist program, seeing patients, etc. And he said, Ken, because you're a young doctor, you've got lots of energy, and it's the easiest money you'll ever make. All you need to do is go to the nursing home and sit in on a couple of meetings and pick up your check monthly.
How did that turn out for you? Is it the easiest?
Well, if something sounds too good to be true, you should know that. But I went, well, great, easy money, okay. So obviously I didn't find it to be that way. And about a year later, my partner said, Ken, I should have never recommended you for that job. And I said, well, why? And he says, because you're not doing it like everybody else. He said, you're there at the nursing home every day. You're going after your hospitalist rounds and spending hours there. And he said, I don't know why you're doing all of that, but I've never seen somebody do that before. And I said, because there's a real need there, and I can't just walk away and not respond to that need. So that's how I got into it, and it's evolved from there.
So how long have you been serving as a medical director or physician to post-acute care services? How long have you done that?
Yeah, probably 15, 20 years, somewhere in there.
Wow. And over time, I'm sure post-acute care has changed as the times has evolved. Can you talk about some of the changes you've seen over the course of 15 and 20 years in post-acute care?
So when I took that job, you know, I decided to go over to the nursing home and actually check it out because other than visiting family members when I was a kid and in a nursing home, I really hadn't spent any time in there. In medical school, most of the time you don't get a lot of training in nursing homes unless you're going into geriatrics specifically. Um, and so I walked into that nursing home for the first time, and when I opened the front door and walked in, the smells were horrific. And that's changed. I really think most nursing homes I walk into now, they're doing a much better job of making sure that the decorum is better and the smells are better in a nursing home for the most part. I really think the biggest change has been that nursing homes have gone from what we consider to be convalescent centers. Really, back 20 years ago, the kind of patient that often went to a nursing home was what you would find in an assisted living facility now. And in reality, the transformation has been that nursing homes really are heading towards freestanding med-surg wards.
Yes.
The complexity of the patients, the needs of those patients. And it's created quite a challenge, I think, for the nursing home industry.
Yes.
And speaks to the need for physicians to be present in a nursing home because of how sick those patients are.
I think it's important, and I want to share a little bit of how we met. So a lot of my viewers know I am from Detroit, Michigan, and I relocated to Hawaii roughly about 2 years ago. And I came into a facility as a clinical consultant to a hospital. And then roughly about 3 months in, I was shifted over into the chief administrative officer seat where we kind of got to partner over post-acute care services. And I saw the difference in how you led as a medical director. You'd physically come in exactly as you're stating and hold your physicians to that same standard. Do you believe that you see better patient outcomes when your physicians are actually rounding on the patients and doing that true follow-up?
Absolutely. And really, what drove me to it is I realized that as a hospitalist, it was really like a mill. I would see an elderly patient, I would stabilize their congestive heart failure, send them to the nursing home, and then wait for them to come back in worse congestive heart failure and stabilize them again and send them back, that kind of a thing. And I realized that, if physicians were actually paying attention to patients in the nursing home setting, we could actually reduce the amount of times a patient was sent back to the hospital. And of course, back then, not long after that, the papers started coming out of the high rehospitalization rates. 21 to 33% of skilled patients to a nursing home were returning to the hospital in 30 days or less. And I thought, we could really impact that if we were paying attention to them. And it's hard to ask nurses that are working in a nursing home where they're taking care of 20-some patients per nurse to see the subtle signs of somebody that's getting sick from, their congestive heart failure is worsening. And when you finally see it, it's too late. That patient has to go back to the hospital.
I think what's interesting is you get it. I was an LPN in a skilled facility, then I got my RN, and what you just indicated is it's a challenge, right? For a nurse, whether you're LPN or RN, I don't see a difference for me personally. It's hard for you to sit here and say you need to monitor those subtle signs when you have 20 to 30 other patients. Don't
Absolutely.
let it be midnight and you have 40 to 50 patients. And we wonder why our RTHs are so high. So as a physician, you play a vital role in RTHs. You play a vital role in really charting the course to reduce those RTHs. And I know when we partnered together, our RTHs were very low. for other medical directors out there and other DONs that may be looking at this podcast, do you have any strategies that you kind of suggest to help reduce that readmission rate? Anything that you'd suggest?
Well, I think the most important thing is having a full-time physician in your building, and everybody gasps when I say
Yeah.
that. Who can afford a full-time doc? How does a doc make it work? Most facilities are about 120 beds, and maybe 30 of those patients are skilled, and the rest are long-term care. So there is a cost that goes into it, but in reality, those costs are offset in multiple ways. Number one, I can tell you that for the last 5 years, including COVID, the years of COVID, with full-time doctors in the buildings that my company was serving with our model, our return to hospital out of all of those facilities rate was between 3 and 6%. And I don't know of any other
Wow.
buildings that have
Wow.
that low of return. And so, number one, that means that patients are, when they come in skilled, they're actually continuing to be stable, which gives them the best chance to get better. And
Yes.
there's more patients going home out
Yeah.
of our facilities where we have a full-time doctor serving. The second thing is that I was able to show that when you reduce your rehospitalization rate that low, not only are you not getting the penalties from Medicare to the nursing home now, which is also penalized, but your actual average daily skilled census goes up by between 3 and 5 patients. And the reason why is because you don't have those gaps where patients are being sent back and the bed is empty. And because of that,
Wow.
that income generation is huge when you look at it over a year to have an average daily skilled census 3 to 5 patients higher.
Wow.
And then another thing that really makes a huge difference is that when you have a full-time doctor in the building, your ancillary costs actually go down, lab, x-ray, and pharmacy.
Yes.
The problem is with the regular model, the way it's normally done, where you have a medical director who also has his own practice in town, maybe sees patients in the hospital. In a doctor's mind, of all of those venues that he or she is serving, the nursing home is supposed to be the most stable. Number
Interesting.
one, his or her office is going to get the most attention because if the lights are on and the doctor isn't there, you're losing money instead of making money.
Wow.
So that's going to be number one. Number two is in a doctor's mind, if there's a call from the hospital, those patients are acutely ill, you better take care of that. That means the call from the nursing home is at the bottom of the list. And it's not because we don't think nursing homes are important. It's because in our minds, those are supposed to be stable patients. And
That's
so,
insightful. That's insightful. Exactly. To hear it from a medical director is interesting because, as I say, the administrators, the DONs, we're going to watch this and we're going to gain a lot from what you just stated. So, like you said, you look at it, it's stable. But the challenging part is, right, if the nurses can't detect, the signs and symptoms because they're so busy, when you get that call, a lot of times those medical directors or physician covering, they say, well, just send them to the hospital because you didn't detect it, right? So,
yes. And they say that for two reasons. They say it because they think, oh no, the patient's getting unstable. But number two, they're going, okay, nursing homes don't have lab in-house. They don't have pharmacy in-house. They don't have x-ray in-house. How long is it going to take me to get anything back that I can make a reasonable decision? They've now put it on my lap and I'm responsible. I don't want a bad outcome. Send them to the ER.
wow. Wow. So how do we curve that? How do we fix that? What can we do in skill where our margins are so thin
Yeah.
And when we send a patient to the hospital, now our margins are even less, right? Because we don't have that revenue coming in. If it's proven to be our fault or whatever the case, sometimes we have to eat the cost on that. So how do we fix that where when we call a provider, the nurses, the providers aren't just saying send them to the hospital. What do you do to keep your RTHs so low? Because you're not just saying send them to the hospital. Your team is not just saying send them to the hospital.
Yeah, but we have an advantage because we're full-time in the facility. So when the nurse calls and says, Miss Brown doesn't look good,
Okay.
I'm going to walk down the hall into Miss Brown's room and look at her.
Okay.
Okay. And it's not that that's just a knee-jerk reaction. I'm going to
Yes.
ask the nurse all the normal questions,
Yes.
what are their vitals? Why do you think Miss Brown is not looking good? What are you seeing? Describe it to me, etc. But ultimately, I'm going to walk down the hall into that room. And two things happen. One is, I can tell pretty quickly by my own exam whether that patient really needs to go to a hospital or not, or whether I have time to get lab to come in, x-ray to come in, adjust the medications, etc. And so, and as a result of that, only instead of having a call from a nurse that's trying to explain what they see with the limited amount of time they have to be in that room while I'm, got my mind on my patient in the office plus trying to answer that call, I'm actually focusing my attention on that patient. And as a result, instead of pan labbing and getting 5 x-rays or whatever it is, only the specific labs that I know are necessary are ordered. And therefore, the cost to the nursing home goes down because ancillary costs are less. 9 times out of 10, that patient never leaves the room. And, to give you an example, I was presenting this down in Florida to a group of physicians down there several years ago. And one physician says, okay, I've got a question. And I said, please. And he goes, so what you're saying is when I'm in the nursing home, that if the nurse comes up to me and says, hey, your patient in room 318 doesn't look good, you expect me to go into that room right then and see that patient, even though that's not the patient I'm there to see. And I said, yeah, novel idea, right? To actually look at a patient that the nurse is worried about, And he said to me, well, let me tell you why your plan won't work. And I said, please tell me why. And he goes, because when that happens and I go into that room and see the patient and I find the patient to be in congestive heart failure and I say, put an IV in that patient, give them 20 or 40 milligrams of Lasix IV push, and I give a bunch of orders, I can see that nurse becoming visibly uncomfortable with that. She's got 30 other patients to take care of. I'm throwing her off of her routine of getting her medicines out on time. I'm giving her all this extra stuff to do. And she's visibly upset with all of that. And I said to him, those are very valid points. I understand what you're saying. Mm-hmm. But I said, let me explain it to you from the other side. Why do you think nurses in the hospital like hospitalists so much? Because they call me and tell me there's a problem, and I walk into the room with the nurse, and we evaluate that patient together. We come up with a plan. I go on to the next floor to see patients. 2 hours later, the nurse calls me back and says, the patients know better. And I'm back in that room with that nurse again. Mm-hmm. That may happen 3 times. At the end of that, the patient's either stable or the patient's been moved to the ICU. And I said, the nurse is happy with that response and getting care for the patient. I said, the reason the nurse was visibly upset with everything you're saying in the nursing home is she knows the moment you walk out of that room, you're also going to walk out of the nursing home. You're going to be back to your office or back to the hospital. And 2 hours later, when that patient's no better, she's going to be calling you and calling you and calling you, waiting for a response. And most of the time, she's going to call the ambulance before she hears from you because the patient's so short of breath. That is why she's visibly upset, not because you've asked her to do things to take care of her patient.
Wow. Profound. And for the audience, this is Dr. Scott, a world-renowned medical director, has been featured in magazines, has done speaking engagements, and you're hearing it first from a medical director, a certified medical director, not just a regular medical director, for what it's worth. So, Dr. Scott, I hinted around about that certification, but how does that certification impact your decision, impact your care that you deliver, and what is your thoughts on becoming a certified medical director?
So if I go back to the beginning, when I took that first job, let me give you a bit more detail. I walked into that nursing home. I smelled all these bad smells. I went, what on earth? Instead of going and meeting the administrator, I literally started walking down halls, and I saw beds unkempt, patients uncared for, etc. And so I decided that I needed to take this job because this nursing home, these residents needed my help. And of course, I had no idea what I was getting into. No idea whatsoever, because I'd never done this before. And about a month later, after working at the nursing home for a month, coming after my shifts as a hospitalist or on my days off, I found myself in the middle of the night, laying on my back, wide awake, staring at the ceiling in a cold sweat and saying, I don't know what I'm doing. I don't know how to function in this environment. And this nursing home is not giving very good care. And my license is now attached to it. This nursing home is going down and my license is going down with it. And I went, now I know why the last medical director ran for the hills. And so with that in mind, I decided I had two choices: do what the last medical director did or step in even more so. And that's when I decided I would show up every day, even if there wasn't a patient on my list that needed to be seen based on a 30, 60, 90-day eval or an annual eval, etc. And I would go into that nursing home and actually go down the hallways, and I started actually helping the CNAs turn patients and wipe butts and clean people up because I knew those
Wow.
patients needed the care.
Wow. That's impressive. And you don't hear that often, right? So I applaud you for your dedication to service excellence, dedication to caring for the patients, and then partnering with the nursing staff, the administrators, the director of nursing over time.
Yeah.
As we come out of COVID, I'm sure COVID has taught us plenty of things. I've learned, I've grown both professionally and personally, and I'm sure you have as well. As we return to the new normal, where do you see long-term care going after COVID?
Yeah. So the first thing I would say is that after COVID, it's even more important in my mind for nursing homes to have a certified medical director, not just a medical director like I was when I started. That certification process educated me on what I should be doing and how to be effective in the nursing home environment. And so I think that ultimately, especially post-COVID, because, during COVID, the rules changed so rapidly as we were trying to understand what this virus is, how it attacked human beings, and how it wreaked havoc on society and in our nursing homes. And so you really needed a certified medical director that understands how to help create policies and procedures and to lead effectively in a nursing home, not just from the standpoint of making sure the patients are taken care of, but actually providing medical leadership to the healthcare staff, because by the end of COVID, everybody had so much COVID fatigue. They were terrified at the beginning to continue to work. The workers were getting sick. How do you take care of the patients with less workers than than you should be having? All of these things. You need that certified medical director to add that level of expertise to what happens. Beyond that, what I would say about where we're going is, there's this, in a way, we're kind of in a crisis mode still in the nursing home industry because, families began to distrust nursing homes during COVID, not only because their loved ones were dying, but they didn't understand this thing of being locked down.
Yeah.
The pictures were horrifying of seeing
Yeah.
families waving at their parents through the window, not being able to come in.
Yeah.
I prepared my nursing home for the fact, I understand we have to lock it down, but we all need to understand that the longer we're locked down, the more down the road. We may save our patients' lives from COVID by locking down, but they're going to start to wither away and die long term.
Yes.
Because the only thing that keeps elderly people going is that connection to their families and friends, and we're taking that away.
Yes.
And we're seeing that now. I'm seeing patients, the amount of depression at the end of COVID, the lack of will in my geriatric patients to continue living. It's all coming to fruition now. So, you need that certified medical director for that. But beyond that, we now have this crisis in not even having enough nurses to keep our nursing homes full. And now that the federal government is going to hand down nursing mandates, levels of nurses needed in nursing homes, it's going to even become harder to completely staff your nursing home. There are lots of thoughts out there in the think tank that maybe we don't need nursing homes anymore. We can do it better with home health, take patients home, all these things. The first thing I would say is that there's a think tank to that, but it's never going to come to fruition. And I can tell you from personal experience as well as just common sense, and that is, we are living longer. Our population is living longer, except for the fact that we had the first downturn in that statistic post-COVID. Life expectancy in America is actually shorter now post-COVID than it was before because of the death rate.
Wow.
So for the first time, the life expectancy in America is shorter. But having said that, we are going to continue because of the advancements in medical science to allow patients to live longer and longer with chronic illness. And I just went through this with my dad, who died in the middle of COVID at the age of 93. My wife is an RN. Between her and me, we took care of him at home. But I will tell you that if it wasn't for our expertise, we could have never accomplished that. And the level of mental and physical fatigue that we had by the time he passed away, I can't hardly even describe, because I was still working full time and so was she.
Wow.
And even with getting caregivers in, we were absolutely exhausted. And so there's always going to be a need for the nursing home, because these patients, these chronically ill, chronic multiple comorbidity patients need some place to get expert care. Having said that, where the nursing home is going is towards more and more towards a freestanding med-surg ward. We have to come to reality that that's where we're heading. The easy patients are not going to be in the nursing home. The complicated ones are going to be there. And we have to find ways to better meet the needs of those patients and provide that quality of care at that level for those patients in the setting that we have. And I don't think that means bringing lab, x-ray, and pharmacy in-house, because then we're a hospital.
Yes.
And we have all the costs of the hospital. The reason Medicare wants us is because we're so much less than having those multiple comorbid patients in a hospital bed. So we have to find a way to meet those patients' needs better than we are now, knowing they're going to get even sicker.
Wow. It's interesting where you say we're going, and I've seen that as an administrator and as a nurse. Patients can go home. There's home care that they can go home to. They're coming to our skilled facility because we offer skilled services that they can't do at home. We're providing complex wound care, maybe TPN, which can be done at home, but maybe you don't have the family or the dexterity in the hands to do that. Major surgeries, not just knees and hips anymore. We're talking about traction and things like that. That's why they're coming to our facility. So as we start to accept these sicker patients, what role do you see technology playing in how we provide that care for our patients?
Well, that's a really difficult but a very good question. One of the answers that's being put out there a lot is telemedicine as a technology that helps. I think that there's a lot of good things about telemedicine that could be added to post-acute and long-term care, but there's some things that telemedicine is not going to be good at. And having said that, let me tell you that all of technology has aspects that are good and bad. Just like every medication that we come up with has good aspects to it and has adverse side effects that don't work with some people. And so we have to, no matter how much we put technology into the picture, we always have to keep the human element front and center in our thinking. And the reason I say that is because telemedicine, when you look at the millennials and the younger people, they understand it and they really like it. But the geriatric patients that are coming to nursing homes, many of them didn't even really use a computer. The highest technology they used was a machine in the kitchen or their television set. And yes, we are getting geriatric patients now that are very computer literate. I'm not saying that. But the problem is, as we age, the human factor becomes so important, and having just technology there and getting away from that human factor, we're going to have the same outcome we did by isolating patients because of COVID. We will actually shorten their lifespan because what they really need is that human touch, that human connection, which is so vital to all of us, even all of us that live on Facebook, and that's how we have our human connection. We know that there is a lot of depression and psychiatric issues out there because of these kind of things. So I'm not discounting technology. I think that it has a vital role. I really think that as nursing homes, many of them are rural. I think having telemedicine and technology there to be able to even connect with subspecialists are very important. And we need that. But we can't get away. We have to figure out a way to use that technology along with the human connection. Otherwise, we're going to fail our residents.
Wow. I think it's important that, like you said, we try to incorporate as much, me with the younger generation, try to incorporate as much as we can of technology, especially with the invention of AI or the push now of AI that's greatly helping nursing homes and hospitals all around. And, without diving too much into AI or technology, I would say I am a fan. One of my masters is in informatics. So that's, all things EMR, technology, AI. And when I talk to skilled nursing operators and I try to talk to them about incorporating technology, a lot of times people are fearful of technology. And what I have to remind people is, and for example, AI, people are afraid of AI. Well, what is it going to do? And I say, well, AI, we've already been using it. And I have to break it down in a way that people understand. We in informatics, we call it a CDU, a clinical decision unit. So when we input data into the software, let's even say PCC or whatever software you use, and it tells us what to do, that is a form of AI. When we take a temperature and it rings red and tells us, hey, this person has a temperature, that is a form of AI, right?
Absolutely.
It's taking that data and giving us something, and then we do something with that data. So I'm a fan of incorporating technology. I'm a fan of using AI to better patient outcomes. I think that we as a community should be striving to better patient outcomes. And when we talk about bettering patient outcomes, one of my favorite areas to talk about is QAPI. I love all things QAPI. What is the MD's role in QAPI?
So the first thing I'll say, just as a basic thing about it, is that in the traditional role of a medical director, it's back to what my senior partner said to me. All you need to do is go to the meeting and sign off on the paper and pick up your check.
Yes.
And if you're dealing with QAPI in that aspect, you're not getting a good feel for, you're getting a bunch of data
Yeah.
given to you that the nursing home or your infection control officer or whoever is putting together, and it may be good data points, but it's really hard to interpret that data. And from the standpoint of adding a meaningful contribution from the medical director, which is why they go in and sign off. Looks good. Hey, great. We reduced our Foley catheters from 10 to 8 this month. Great. Way to go. Let's see if we can get rid of one more next month, and in reality, I go back to my early days as a hospitalist. One of the hospitals that I worked in, they went through a period of time like every hospital does, where the community is less happy with you. There's more complaints. The hospital isn't making as much money. They're cutting back on staff, and everybody's feeling the pinch, so to speak. And so this hospital was in that kind of phase. And so one thing they decided to do to try to turn the hospital around was to appoint a physician liaison to every floor of the hospital. And so I was appointed as the physician liaison to the heaviest med surge ward of the hospital. I was a hospitalist there, and they did the right thing. I had a lot of patients up there all the time, so I was on the floor all the time. Yeah. The point of that is, instead of, yes, I met with the charge nurse, and we reported to the head of staff for the hospital. We reported our statistics, and we could compile it all and everything else. But where the rubber really met the road is when the charge nurse and I looked at an individual problem, went and talked to the nurses about the problem. I conferred with the doctors, the specialists that were coming up there, about what they were seeing. I saw the problems in real time because I was there, and I was talking to the patients that were experiencing those issues. The data points are really important to have. And I think again, back to the AI thing, there's much more we could do if, we're really just getting nursing homes to the point where they're becoming more electronic. So many of the nursing homes I'm in are still hybrid. They're half paper and half computer. It's a mess. We really need to be completely on computerized. And one thing that I think would aid a lot that I've not been able to solve yet is the ability within the computer system to actually correlate health outcomes over a broad spectrum, not just one nursing home, because that shows you how healthcare individuals in that nursing home are responding to a given health condition. But what about if you could look at nursing homes across the United States with patients that were there with congestive heart failure and an EF of 25% or less? That's a really complicated patient that lands in a nursing home, and see what the outcomes are across the board and what the differences are, and look at, and then you have something to work with where you could actually say, hey, this is best practice in the nursing home setting. And frankly, most of the research that has been done in healthcare today has not been on geriatric patients that are over the age of 75. And that's what we're taking care of in the nursing home most of the time. And we need the research. Our nursing homes are wonderful places to be able to do that, but we don't even have the AI or the computer technology in there well enough, or even linked up well enough to be able to correlate that kind of data.
Wow. It's such a refreshing conversation to be able to speak candid with a medical director and share this with the viewers. As we get ready to draw close, What piece of information would you like to share with the long-term care community, whether it's medical directors, administrators, directors of nursing? What would be your last statement to them about long-term care?
I guess my last statement would be to say that I would challenge the post-acute and long-term care community to find new and better ways to engage your medical director and to question how well your medical director is acting as part of your team in your nursing home and how well your medical director knows your staff. And an example would be, I have the privilege of the facility that I'm in full time, of being there every day. I'm full time in that facility. During COVID, I walked into the rehab gym one morning and didn't recognize one face other than the director of the rehab department. And I went to the director of the rehab department and said, who are all the new people working here? Oh, well, the local hospital has so much COVID in it that there's nothing for rehab to do, and we needed more help. So I brought their rehab people up to work here. And of course, my response was, well, have we tested all of these rehab people for COVID, even though they're asymptomatic? Have we done a PCR on them? Well, we know they were tested sometime down there at the hospital. No. Retest them all right now. We did, and one was COVID positive and asymptomatic. And so, my point is that most medical directors that don't show up in their building every day don't even know if there's a change in staff. You can't recognize it.
Wow.
And so I would just ask to look at what you're doing to make sure that your medical director is actually a living, breathing part of your staff, rather than like a consultant that just shows up once in a while to sign off on the paperwork and give a little advice while they're running down the hall to see their latest 60-day eval that they're late on, and I know that sounds bad to paint it that way. Believe me, I have been in hundreds of nursing homes over the country, and I'm not talking from something that I haven't seen on a pretty regular basis to occur. And then the other thing that I would say is that if you can look at figuring out how to get your medical director more involved, then the second question is, how are you utilizing that medical director to become a better facility? Because in reality, nursing homes historically, to begin with, they didn't even have to have a medical director. And then when they started to receive Medicare funding, Medicare said, you have to have a medical director of record to ensure quality of oversight of your facility if you're going to get Medicare funding. So then medical directors started to happen. But it's really been hard to see it evolve much past that. And in reality, your medical director is a wonderful resource. And if the medical director doesn't want to do that because they're too busy elsewhere, you've got the wrong medical director, because that medical director is key to helping you become a better facility.
Wow. Dr. Scott, I thank you for taking time out of your day to chat with me and come on common ground with SMK Medical. I know you own your own company, Silver Sage. How can people get in contact with you should they have any questions about medical directors? Maybe they're looking for a medical director.
Yeah, and we're more than willing to help with those kind of things. I mean, you can reach out to us at our website, silversageUSA.com, SILVERSAGEUSA.com. And look us up on the website, reach out, love to hear from any of you. And We'd love to help if we can. We not only supply doctors to facilities, but because of the being asked, we also help with recruiting of nurses to nursing homes now.
Wow. Thank you, Dr. Scott. Bravo. I appreciate you. I appreciate what you have done for the long-term care community, and just the knowledge that you've shared with everybody on this podcast. I think it's going to be valuable for administrators, DONs, medical directors, internal medicine doctors, discharge planners, everyone to view this podcast and get some insight to what it's like to be a medical director and the thoughts of your the thoughts of the role. So I just thank you. And I thank everyone for joining us on Common Ground with SMK Medical. We hope that our discussion with Dr. Scott provided valuable insights into the industry's pressing issues. We'll continue to strive to create a safe space for meaningful conversations on healthcare, and we look forward to bringing you the more information and engaging episodes. Stay informed, stay engaged, and stay tuned to Common Ground with SMK Medical. If you've enjoyed this episode, please like and subscribe to our social media pages. You can follow us on YouTube and at LinkedIn at SMK Medical, and you can follow me at Your Healthcare Consultant on Instagram and TikTok for more healthcare related content. Thank you again for watching.
Thank you, Demetrius.